I'm on 864, dispatched to a 35-year-old male, fall patient. So I arrive on scene, BSI, the scene appears to be safe. Looks like I have one male patient laying on the ground. It's not icy out, not cold, and he's just looking at me. And I walk up, "Hey, sir, how you doing?"
Hi, thanks for coming.
Yeah, so you fell, and what'd you hurt?
Yeah, I was just getting ready to take my dog for a walk and got kind of just tangled up, and he kind of took off, and I just fell down, and my elbow really, really hurts.
Okay, so I do a quick blood sweep. I find nothing. I do a primary assessment, and I go from neck, head to toe, and the only pain he tells me he has is, you said it was your left elbow?
Yeah.
Awesome. And so since you don't have any other issues going on, I'm going to just take a look at it. And I have good distal circulation, and it looks like maybe potentially there's a fracture. It's pretty swollen. And so I'm going to have my partner check a set of vitals. And the vitals are blood pressure 132 over 80. Heart rate is 88, respiratory rate 16, O2 sats 98, and we are going to do a sling and swath on this. Sir, besides the left elbow pain, I just want to make sure nothing else is going on. So you just slipped and fell. You weren't like losing consciousness first. This was just an accident.
Yeah, no, the dog I kind of got tumbled up. I'm totally healthy otherwise. I just got tripped up and fell down and just kind of caught myself.
Perfect. And so do you have any medical history? Have you ever had falls before or any other medical problems?
No, years ago, like in high school, I broke my shoulder, but I don't. No, I'm good.
Okay, do you take any medicine for anything?
No, I just, smoke weed occasionally, just, to kind of relax, but no, I'm not, no.
No, okay. Allergies to anything?
Yeah, I have an allergy to bioxin. It's like a I used to get strep throat all the time, and it was one of the things I used to get me, but no, nothing else really other than that.
Nothing else, okay. And anything, just in case you have to do surgery, the docs like to know if you had anything to eat today or drink.
Yeah, I just had, some salad and stuff before I went out for a walk, just my normal lunch. Yeah.
Okay. And last question, I know I already touched your whole body and everything, didn't find any other injuries, but I didn't notice anything on your head. Did you hit your head or lose consciousness at all?
No, I was able to totally catch myself. No.
Okay.
I'm good. Yeah.
Perfect. Okay. And then, so we're here in our aid car. Obviously you're probably going to need x-rays and stuff. My partner's got you in the sling and swath and an ice pack on your hand. You have good distal circulation post sling and swath. So the question is, which hospital would you like to go to? Closest one would be Evergreen.
Yeah, I don't know any of the hospitals. I mean, if that's where you guys think I should go, yeah, that's fine with me.
Yeah, that'd be great. Okay. Excellent. Well, sounds good. So we're going to hop in the rig. I'm going to just do a secondary assessment. So, I'm adding a couple things that I didn't check on the primary, such as, looking in the pupils, ears, mouth, listening to lung sounds, and I don't find any other issues. And we go drop them off at Evergreen. I get a second set of vitals, and they're the same. So that's pretty much that. So what I'm going to pull up for you guys is I'm going to just show you so all of you can see kind of what a report would be on that specific patient. Then we're going to do one more brief little scenario, take some notes on it, and you guys will be done for today, okay?
So let me question. Sure. Go ahead, Grady.
Yeah.
Go ahead, Grady.
Nielsen got kicked out again. Somehow.
He's going down.
Something wrong with him. No, there shouldn't. There we go. Yeah, there shouldn't be. He should be back in. There you go. Cool.
Yeah, he just said he's back. All right, thank you.
Are you guys able to see my Word screen that I just pulled up? Like my blank white document?
Yep.
Yeah.
Okay, cool.
Yep, we can see it.
Awesome. So I'll just kind of show you, based on that little scenario we had, I just wrote a couple notes for myself when we were doing it, but I'll just show you how I would do it. And like I said, each person kind of comes up with their own style after a while. I actually still put an S on my reports just because that's how I've always done it. A lot of people don't, but that's the way I do it. So we'll just start out with 35-year-old. And so I do Y/O, year-old male, complaining of left elbow pain, second to ground level fall. So what I've said here is, I said, age and gender, what his chief complaint is, and how it happened. And so this is just the second is like secondary to a ground level fall. It's just a term that I use. And a lot of people do. What you will notice with the people that have been doing this job longer, they use more abbreviations. And the reason why is we used to have to handwrite everything. And that was up until about 2014 or so. And so once you're handwriting these so often, you try to shorten up everything, and that's why there's a lot of abbreviations used. So 35-year-old male complaining of left elbow pain, second to ground level fall. Patient states he tripped due to his dog. Patient denies any other pain and or loss of consciousness. And so the reason why I put that is called a pertinent negative. So it's important to tell the reader that to paint a picture, that's what I'm really trying to do with that S. I'm trying to paint a picture so if, 10 hours from now he ends up having a head bleed, then they can go into this report and go, hey, well, he just fell ground level. He doesn't have any other pain, no loss of consciousness. And so that's pretty much it. One other thing that I'm going to show you that I would normally do is at the very top of my report, I put important things that I want the reader to know. So let's say this was a different type of call. We'll say it was chest pain, and the person had a history of a heart attack last year. PMHX means past medical history, and I would put MI 1 year ago. So if I want to put important past medical history, I do it right there. The other thing is sometimes a person will say, like in a chest pain call, they might say, oh, this discomfort feels exactly like my last heart attack. I would put it right in here. We'll do medical reports another day. Today, we're just going to do this basic trauma report. So you got that. Next thing, O. So the O that I usually like to do is I always start of kind of what did I see when I got there. So on arrival, patient, supine, on ground, AO, I usually say GCS of 15. So he's alert and oriented, looking at me, talking to me. Skin warm, dry, and pink. Speaking in complete and clear, non-labored sentences. So what I've done there is that in one sentence, I basically I'm showing how the patient is positioned, their level of consciousness is normal. I don't see any issues with their skin, or, I felt their skin, and it's dry also and warm. And then they're speaking in complete and clear, meaning not slurred, not short sentences, and it's non-labored. So I've told a lot of things. I've said ABCs are intact. Level of consciousness is good. skin's good, and this is how the person's lying on the ground. And if there was something unique, I would say it. Like if he's laying on the ground screaming and holding his leg, I would say on arrival, patient's supine on ground, clenching his left leg and screaming. So you just want you want to like paint it so you can remember it too if you ever need to testify to it, especially. So that's my first sentence. The next section of O for me is, let me just do this real quick. The next section for observation for me, this would be where I'm going to put in vital signs if I choose to put them in, other pertinent information such as blood glucose level, any sort of kind of objective information I receive from the patient or from a diagnostic tool. So we'll just do it on this one here. I'll say blood pressure was 132 over 80, and then heart rate was 88, respiratory rate was 16, O2 sat equals 98%. 98%, and then I put RA. That means on room air. So you always, if you're ever writing down what an oxygen saturation is, you want to say whether it's on room air or whether you have oxygen on this patient. And then we'll say we got a blood glucose level of 124. So that's kind of all their vital signs really quickly there. And then we're going to go down and I'm going to show you how to document each area. So the first one I like to use is heme. So that's head, ears, eyes, nose, throat. And so because this was a trauma patient, a fall patient, I'm going to talk about a few things. And the things that I checked were no obvious injuries. So I just said no obvious injuries to all that area. Then I can say anything else I want to say in particular. And one thing I would in particular look at when a person falls is I need to be thinking like, hey, okay, maybe it was just a trip, but maybe the person's got a neurological issue. So I almost always make sure I look at the pupils and state. So I'm going to go pupils equal MER, midsize, equal, and reactive. And then the only other thing which, two other things that could apply to trauma would be in the throat area, no JVD and no trach deviation. So I've pretty much said some of the main things in the face. Now, if it was, I could also say, if I wanted to, I could say no battle signs, no raccoon eyes. The reason why I didn't is because I believe I covered that with no obvious injuries. But that does not cover JVD and it doesn't cover tracheal deviation, which could be involved in a trauma if a person's having a pneumothorax. So that's the first part. Next one, go down. Okay. I like to put two together. A lot of times I go back, neck. And so when I think of neck here, I'm thinking about the back of the neck. This here, N is nose, and then the T is throat. So I will just say on this, no obvious injuries. Next, I would do chest. So in the chest, I'm not only checking for injuries, but I'm also checking the lung sounds. So I always state the lung sounds first. And for me, the way I do it is I go L/S, which is lung sounds. And then on my finding, equals, and I'm going to say another abbreviation is CTA-B, clear to auscultation bilaterally. So that is general if I don't have anything in there. If I had something in there, I might say lung sounds equal, we'll just say wheezes bilaterally, lower fields. Or I might say wheezes bilaterally, up and down, meaning the whole lung. But with this guy, it was just lung sounds equal clear to auscultation bilaterally. Then the next thing I need to talk about the trauma exam. So I'm going to say no obvious injuries, and I might say equal rise and fall, meaning I've looked for injuries, I've listened to breath sounds, and I've also watched and made sure the mechanics of the person's chest are fine, equal rise and fall. Next is abdomen, ABD. With that is if there's nothing wrong with it and I have palped the belly, I'll go soft and non-tender. So I didn't get any pain response when I palpated it. Next would be, I like to say pelvis. I go pel/hips, pelvis and hips. And I will say no obvious injuries. And another thing you can put also is if you want to show that you did palpate, let's just say no tenderness on palpation. And then we come to the extremities, EXT. For the extremities, I can say all extremities had good TMS, all extremities. Before and after splint. So that basically covers all four no matter what. And then the next thing I would say is obvious ecchymosis or bruising. If you don't have spell check, well, I didn't even spell that right either. Obvious bruising and swelling left elbow. And, that's all I'm going to say on that. So basically in that observation, I've covered my entire exam. From the top of the head all the way down, I've listed information. Finally, next assessment. My assessment is left elbow injury. So I don't need to say left elbow fracture. I'm just going, hey, it's an injury. The hospital will check it out. I don't need to be super detailed. We don't need to make a diagnosis here. It's kind of our best guess, or what, if you were handing this piece of paper to a doctor, what you would want them to check. The final is the plan. What did we do? And how did the scene end? So I did a patient exam, PE, P/E, patient exam. We checked vital signs. We checked an O2 sat. We checked the blood glucose level. You want to document that because you are putting, a needle into a person basically. So make sure you document it when you do it. Patient exam, vital signs, O2 sat, blood glucose level, splint, sling and swath, and we'll say an ice pack, and then aid 151, transport to Evergreen emergency department. Now, the final thing is, and you don't need to do this on every report, this is probably maybe 1 in 10, 1 in 20 reports for me, is like you saw on Instructor Reed's report, she put note. Sometimes it's change, sometimes it's additional information. So let's say I'm going to just go change. And I'll say, while en route to Evergreen, patient's level of consciousness decreased, and patient's, that's too crazy. While en route to Evergreen, patient stated he lost feeling in the fingertips of his left hand. Patient still had a strong distal radial pulse on left side that was equal to the radial pulse on the right side. So if something changes and you've done all your assessment and everything and there's a change, you want to put it there. That would also be the place where if you administered medication such as epinephrine, you could put post-medication administration, this is what happened. So anytime you need to make a little note, a change, that's what you do. So here's just a stereotypical, that's a basic report for a trauma patient, minor injury.